I'm Alex Rae-Grant, staff neurologist at the Mellen Center for Multiple Sclerosis at the Cleveland Clinic. Welcome to our Multiple Sclerosis Virtual Grand Rounds series. In this session, we will explore the important topic of the diagnosis and management of optic neuritis. Dr. Robert Bermel, Medical Director for the Mellen Center for Multiple Sclerosis, will talk to us about the diagnosis and differential diagnosis of optic neuritis, the critical importance of imaging and sometimes CSF testing in predicting the likelihood of progression to MS, and the standard of care for acute optic neuritis treatment. He will also introduce us to a relatively novel technology, Ocular Coherence Tomography, which is beginning to allow us to chart out the progression of nerve fiber layer thinning in optic neuritis. In this, as in our other MS virtual grand rounds, he will use case examples to emphasize the importance of a good clinical history and exam in the diagnosis of this relatively common neurological condition.
Hello. Welcome to Multiple Sclerosis Virtual Grand Rounds. My name is Robert Bermel. We have certain objectives for the program today. What we'd like to do is teach you about visual involvement in MS, and specifically, at the end of this program, you should be able to identify classic features of optic neuritis, learn how the optic neuritis treatment trial impacted the treatment of optic neuritis, estimate the risk of MS after optic neuritis, and you should be introduced to optical coherence tomography, including its current uses in MS. First, let's start by talking about optic neuritis and the optic neuritis treatment trial. Optic neuritis is defined as inflammation of the optic nerve, but let's talk a little bit more about how it actually presents clinically. Clinically, optic neuritis is identified as painful monocular vision loss. This manifests as periocular pain, especially with eye movement. So the patient looks side to side or up and down and notes that they have unilateral pain, usually at the temple, or periocular pain. The vision loss generally presents as progressive monocular loss over either hours or days. It's described as abnormal visual acuity, so blurred vision, impaired color vision, colors classically looked dulled out. Red desaturation is one of the classic findings in optic neuritis, and potentially loss of visual fields, including central or centrocecal scotoma. On examination, there will be an afferent pupillary defect. This is identified using the swinging flashlight test, and the pupil of the affected eye will actually go up when the flashlight is swung into the affected eye. Both pupils will actually dilate slightly as their first movement. That's how you identify an afferent pupillary defect using the swinging flashlight test. When you look into the back of the eye, the most common finding to identify would be a normal optic disc, though potentially if the optic neuritis is very far anterior, there can be some disc edema associated with it. It's always unilateral disc edema, though, in optic neuritis. Later, following the acute phase, you can see optic disc pallor or atrophy. The time course of optic neuritis, as I said, comes on over hours to days, and visual loss recovers over weeks to months. Because monocular vision loss is not always due to acute optic neuritis, we also need to talk about a differential diagnosis of optic neuritis. One of the most common entities which we need to differentiate from optic neuritis is ischemic optic neuropathy. We'll talk about that a little bit more in a minute. But there are also other inflammatory conditions besides inflammatory optic neuritis that can cause similar symptoms. Hereditary conditions, including Leber's hereditary optic neuropathy, can cause bilateral or unilateral monocular vision loss. It's usually painless, not painful. Infiltrative lesions or tumors of the optic nerve or compressing the optic nerve can cause similar findings. Toxic or nutritional problems generally present as bilateral vision loss or bilateral optic neuropathies and typically progress over a more chronic time course. Glaucoma certainly can present as monocular vision loss with pain, and so that's an important entity to exclude using intraocular pressures. And certainly retinal or macular disorders can also present with findings similar to optic neuritis. Ischemic optic neuropathy is one of the most important entities to be able to differentiate from optic neuritis. However, they actually present quite differently. Ischemic optic neuropathy tends to present at an age greater than 50 years, can have systemic signs such as in giant cell arteritis, can have abrupt onset, and pain is uncommon. Field loss is usually altitudinal as opposed to the central scotoma that you can find with optic neuritis. So an altitudinal field loss means that there's a horizontal line that the patient perceives a vision loss either above that line or below that line, and this would be atypical for optic neuritis, but very typical of ischemic optic neuropathy. Ischemic optic neuropathy, it is actually more common to have disc swelling, especially sectoral disc swelling. You can have disc hemorrhages on fundoscopic exam that are seen, and classically in ischemic optic neuropathy, there's minimal or no recovery, whereas recovery from acute optic neuritis is actually more the rule. So I've provided a summary table showing the differences between acute optic neuritis and ischemic optic neuropathy. Again, the age is different. Patients with optic neuritis tend to be younger. Pain, almost universally present in optic neuritis and extremely uncommon in ischemic optic neuropathy. Visual field loss is central in optic neuritis and altitudinal in ischemic optic neuropathy. And the disc is normal 2/3 of the time in optic neuritis, and in ischemic optic neuropathy swollen or with sectoral disc hemorrhages. The optic neuritis treatment trial is the largest optic neuritis study conducted to date. Funded and executed through the National Eye Institute, it enrolled 457 patients with acute optic neuritis. They were divided into 3 treatment groups: placebo, oral steroids, that's 1 milligram per kilogram per day of prednisone, versus solumedrol 250 milligrams 4 times a day for 3 days, followed by an 11-day oral prednisone taper. The patients were initially followed for 6 months, though now there's been over 10 years of follow-up for this important study group. The goals of the study were to determine the speed of recovery, the ultimate degree of recovery, and any treatment complications from the different steroid arms. The initial primary results of the optic neuritis treatment trial showed that IV solumedrol or methylprednisolone provided faster recovery than oral steroids or placebo. However, there was no difference in ultimate vision recovery at 6 months between the 3 different groups. At 12 months, we were able to look at how well the patients actually wound up recovering eventually. And you'll see that patients went to 20/20 vision or better in the affected eye 69% of the time, 20/40 or better 95% of the time. And bad outcome, or 2200 visual acuity or worse, only occurred in 3% of cases. So this tells us that the natural history of optic neuritis is actually quite good if you look at black-on-white visual acuity. So using a black-on-white eye chart as a 12-month outcome measure, most patients, the vast majority of patients, 95% of them, will get to 20/40 of visual acuity or better, and that's ability to read newsprint. So very good outcome by black-on-white visual acuity. However, if you look a little bit deeper into the data, more than 50% of the patients report slight problems with their vision or worse than slight problems, especially problems such as their vision being poor when they were tired, poor night vision, poor vision in bright sunlight, trouble focusing on moving objects, impaired color vision, or other subjective visual complaints. So we know that there's a little bit of a disconnect between what we call an excellent visual outcome on black and white eye charts and what the patient perceives as an excellent visual outcome, especially in periods of visual stress, such as low contrast situations, vision at night, or in rainy situations. Now, another important result of the optic neuritis treatment trial was which patients went on to develop recurrent demyelinating events at the 2 years or 5 years of follow-up. So patients with recurrent optic neuritis at 2 years were more likely to have been in the oral prednisone group. And in fact, 30% of the patients who received oral prednisone had recurrent optic neuritis by the 2-year time point. That's compared to 16% in the placebo arm and 13% in the IV steroid arm. So patients who received IV steroids were less likely to have had recurrent optic neuritis by 2 years. If we look at 5 years and which patients went on to develop a second attack, any second demyelinating attack, patients in the IV steroid group were also less likely to develop a second attack, or what we would call clinically definite MS, CDMS. And so patients in the IV steroid group, 27% went on to develop clinically definite MS versus 31% in the oral steroid arm and 32% in the placebo arm. So the optic neuritis treatment trial really led to practice changes, and this is borne out in the current American Academy of Neurology guidelines, which state that oral 1 milligram per kilogram steroids have no effect on visual function in monosymptomatic optic neuritis and really has no current role in the treatment of acute optic neuritis. High-dose IV methylprednisolone, or ACTH, may hasten the speed and degree of recovery, but there's no evidence of long-term benefit for visual function. And so the decision to treat with IV steroids should really be based on patient factors. Now, when considering patient factors and whether or not to treat with IV steroids, side effects, of course, come into play. And so we can also look at the side effects that were followed up on from the optic neuritis treatment trial. Of 457 patients in the ONTT, there were only 2 serious adverse events. They both occurred in the IV steroid group, and they both resolved. One was a psychotic depressive episode, and the other was an episode of acute pancreatitis. Just to compare some other side effects that we know occur with IV steroids, things like sleep disturbances occurred in 53% of the IV randomized arm, mild mood changes in 30% of patients, stomach upset in 50% of patients, facial flushing in 23% of patients, and weight gain appeared to be transient because the groups were essentially stable by 6 months. So the thrust of this is that minor side effects are common with short-term high-dose IV steroids. However, IV steroids are safe and feasible to be given as an outpatient. And in fact, that is how we give IV steroids. They're most commonly given in the outpatient or even the home care setting for patients with acute optic neuritis. So, in summary, treatment with oral low-dose prednisone course would not be supported by evidence in response to optic neuritis, and IV methylprednisolone 1,000 milligrams daily for 3 days is supported by ONTT evidence and is commonly how we treat optic neuritis these days. In my practice, the decision to treat is based on the severity of the optic neuritis, and we use approximately a 20/40 visual threshold. If they're better than 20/40, chances are they'll recover quickly on their own without IV steroids, but worse than 20/40, we generally consider for treatment with IV steroids. And of course, we consider the side effects and the patient's comorbidities. If the patient has brittle diabetes, for instance, IV steroids do cause transient hyperglycemia, and we'd want to take that into effect. If the patient really needs IV steroids, we would potentially have them covered by their primary care physician or endocrinologist with a sliding scale of insulin, for instance, during that time. Moving on, one important aspect of optic neuritis is that it is one of the most common clinically isolated demyelinating syndromes that is an early presentation of multiple sclerosis. And after treating the acute optic neuritis episode, the most common question that patients and clinicians have is, what does this mean about the potential to develop MS in the future? So let's consider this subject for a few minutes. When asking who's likely to develop MS after acute optic neuritis, the most powerful predictor of who's going to develop MS is the presence of an abnormal brain MRI. So, looking at follow-up from the optic neuritis treatment trial, at 10 years, overall 38% of the patients wound up developing MS. Now, let's break that down into patients who had no lesions on their baseline MRI scan of the brain. They were less likely to develop MS at 10 years. And so 22% of those patients, the patients with no lesions on their baseline brain MRI, went on to develop MS. Whereas if they had one or more typical lesions, they were 56% of those patients went on to develop clinically definite MS. And what's interesting is that of that 56%, just about all of them had developed MS by 5 years. There are some other factors. If you look at the patients with no MRI lesions at baseline, that were associated also with lower risk of developing MS over time. In males, there was 1/3 the risk in females. Optic disc swelling was less likely to develop MS, and features atypical for optic neuritis, such as vision with no light, very impaired vision with no light perception, no pain, severe disc edema, peripapillary hemorrhages, and retinal exudates. In other words, features that are atypical for optic neuritis incurred a lower risk of developing multiple sclerosis in the long term. If we look at this on a survival curve, based on years after randomization into the optic neuritis treatment trial, you can see that the groups divide into their cumulative probability of MS segregated based on the number of MRI lesions that they have at their baseline MRI scan. The group with 3 or more lesions is most likely to develop MS over time. The group with 0 MRI lesions on their baseline brain MRI is least likely to develop MS over time. And you'll see that the curves start to separate very early on, within the first couple of years. And within 5 years after randomization, really many of the patients who have developed MS, who are eventually going to develop MS, have already developed it. So one of the common questions that we get from clinicians is, does spinal fluid help to determine whether someone's at high risk or low risk for MS? So I want to reiterate that the number one best factor in determining whether or not someone's at risk to develop future demyelinating events after an episode of optic neuritis is the brain MRI. However, in patients where the MRI was negative, a finding of positive oligoclonal bands in the spinal fluid can provide some additional predictive value. So in the optic neuritis treatment trial, 76 of the patients had CSF analysis at trial entry, and 29% of those developed MS by 5 years. At 5 years, only 16% of those without oligoclonal bands went on to develop MS, whereas 42% of those with oligoclonal bands went on to develop MS. And again, the difference in these groups is actually much greater if you look at the patients with a normal MRI. So if the MRI was normal, 27% of the patients with oligoclonal bands in the CSF went on to develop MS despite a normal brain MRI at the outset of the study, versus only 4% of those with normal brain MRI and negative spinal fluid. So in a patient with an abnormal brain MRI that's typical for MS, we typically do not check spinal fluid unless there's some reason to suspect that there's an entity other than MS, if there are atypical features, in other words. If the brain MRI scan is negative and the patient and the clinician need additional predictive value, sometimes spinal fluid analysis can be of use. Of course, there are other confirmatory tests to consider, including things like evoked potentials or MRI scan of the cervical spinal cord to identify factors that would show dissemination in space. So, optic neuritis cases, what do we do in these situations? Well, we focus on individualized decision-making, and really, after an episode of acute optic neuritis and we're trying to determine a patient's treatment and risk for MS, there are a few different options. One would be to watch, both clinically and with MRI scans over time. The second option would be to gather more supportive data, such as CSF, MRI of the spine, or evoked potentials. And the third option would be to treat at the time of the event with a disease-modifying therapy for MS. Let's consider a couple of cases that might help to illustrate these points. Case 1 is a 29-year-old woman who presented with left eye optic neuritis 1 month ago, currently recovering, and when you see her in the office, she has a visual acuity of 20/40. On further questioning, she has a prior episode of left arm numbness that lasted 3 weeks and then resolved, so she never went to the doctor about it. I show you here her brain MRI scan from the time she's seen in the office, and you'll see on the 2 panels on the left-hand side, these are flare axial slices showing multifocal T2 lesions that are periventricular and subcortical. The center 2 slices, both top and bottom, are T1-weighted post-gadolinium MRI scans showing at least 3 or 4 gadolinium-enhancing lesions. And then the panel on the right is a sagittal flare to illustrate the morphology of these lesions. So, in case 1, what to do? Choice 1, monitor clinically. Choice 2, monitor with MRI. Choice 3, gather more supportive data, such as CSF or MRI scan of the cervical spine. Choice 4, recommend treatment with MS disease-modifying therapy with or without an initial course of IV methylprednisolone. In this case, the MRI scan of the brain is typical for multiple sclerosis and in fact shows active demyelination in the form of gadolinium-enhancing lesions. And therefore, in this patient, I was able to make the diagnosis of multiple sclerosis at the time of their acute optic neuritis. We did advise a course of IV methylprednisolone due to the active inflammation on the MRI and the patient having residual impaired visual acuity from optic neuritis. And at the time of diagnosis, we recommended starting disease-modifying therapy for MS because of the certainty of the diagnosis, that is, all factors being typical of early relapsing remitting multiple sclerosis. In fact, the current diagnostic criteria for multiple sclerosis allow for making the diagnosis at the time of a clinically isolated syndrome, such as acute optic neuritis, if the MRI scan of the brain shows both dissemination in space and time in the form of some lesions which are not gadolinium enhancing, combined with some lesions which are gadolinium enhancing. In other words, showing that there have been some lesions which occurred previously and some lesions which are current. So in this case, we recommend choice 4, recommend treatment with MS disease-modifying therapy with or without an IV methylprednisolone course. Let's consider a second case. This is a 45-year-old man with optic neuritis and no prior neurological symptoms at all on history. Other than the visual exam, his neurological exam is otherwise normal, and I show you here 4 slices of his brain MRI. These are all 4 flare axial sequences, and you'll see a few tiny, or as I would call punctate T2 hyperintensities on the brain scan. So in this case, case number 2, what would be your choice of action? Choice 1, monitor periodically but clinically. Choice 2, monitor periodically with MRI. Choice 3, gather more supportive data. Or choice 4, recommend treatment with MS disease-modifying therapy now. In case 2, pointing out the abnormalities on brain MRI, they occur in the deep white matter, not truly the periventricular white matter or the subcortical U fibers. And these tiny punctate lesions in the deep white matter are actually less specific for multiple sclerosis than what we saw in the last case. In fact, on the highly sensitive MRI scans that we get today, we see these types of tiny deep white matter lesions commonly in even normal individuals who volunteer as normal controls for research studies. They're also more commonly identified in patients with migraine headaches, though the reason for this is not entirely clear. What may be perceived potentially as periventricular lesions may be a flare artifact called ventricular capping, which in this patient is seen adjacent to the frontal horns of the lateral ventricles and should not be confused with multiple sclerosis lesions. So in case 2, what I would recommend is choice number 2, monitor periodically with MRI. And in this patient, we decided to check an MRI scan of the brain 6 months from the initial scan without starting MS disease-modifying therapy or making a diagnosis of MS. In fact, in this patient, they're substantially less likely to develop MS over time than the first case that we discussed. Moving on, I'd like to spend the last bit of time that we have together introducing you to a technology called Optical Coherence Tomography, or OCT, a test which is making its way into the MS field to investigate the visual system. We all know, as neurologists, we look into the back of the eye, and we look at 2 areas in particular. 1, the optic nerve head, and 2, the macula. These areas are both accessible by OCT. OCT is an office-based test that uses near-infrared light to generate cross-sectional images of the eye. And so it's a machine that the patient sits in front of. It uses near-infrared light, and it is very fast. It takes approximately 2 seconds or less to acquire a scan. It's painless. There's no risk to the patient. There's no pupil dilation required. It works similar to ultrasound imaging, except it uses low coherence light waves instead of sound waves. So the light waves come out of the machine, they bounce off the retina, the different layers of the retina, and they're reflected back into the machine, and the machine is able to integrate the different light waves that are coming back to provide a cross-sectional picture. To give an idea of what the images and the data from the device look like, when I mentioned that we can look at the optic nerve head area using OCT, the way that data is presented from this is in the peripapillary retinal nerve fiber layer thickness. I show you on this slide a typical report from an OCT instrument of what the peripapillary RNFL thickness report looks like. Along the bottom left and bottom right of the report, you see the actual cross-sectional images, which are then used to generate the data, the quantitative data, in the form most commonly of average RNFL thickness, seen at the center top of this figure. In this patient, in the right eye, or OD, the average RNFL thickness is 83 micrometers, and in the left eye, 81 micrometers. What does this mean? This means that if you take an area of a circle, and in these figures, it's actually a purple circle that the machine artificially draws around the optic nerve head seen on the fundus photographs. If we take that circle and take the average retinal nerve fiber layer around that circle, in this patient in the right eye it's 83 microns, and in the left eye 81 microns. And overall those numbers are colored green on the report, and that tells the reader that compared to a normative internal database, this patient's average RNFL thickness is normal. However, if we look a little bit more closely at the bottom center portions of this report, what we see are a couple of segments of that circle in this patient that are colored yellow. And in the right eye, it's the temporal and the inferior segment. In the left eye, it's an inferior segment. And that tells you that there are some sectors of this patient's peripapillary RNFL that are thinner than they should be. Actually, in this case, less than the 5th percentile compared to a normative database. The RNFL is of great interest in multiple sclerosis because it's home to unmyelinated axons. And so we can very sensitively measure what these unmyelinated axons thickness is over time in MS. The second area of the retina that we can look at is the macula, as I mentioned. We can measure total macular volume, and in this patient, shown in the next figure, in the right eye, looking at the macular volume, it's normal, measured as the cube volume here, 9.4 cubic millimeters. However, also on this report, there are 3 sectors which are identified as somewhat thinned. That is, they show up yellow with the numbers 284, 296, and 300. Again, we get the sense that there are some subtleties in these numbers which show that some sectors of the macula may be somewhat thinned, perhaps as a result of prior optic neuritis, even if it was mild and potentially even subclinical or not noticed at the time by the patient. The macula is of particular interest in MS because the ratio of photoreceptors to retinal ganglion cells there is very high, and so it's nearly 5 to 1 in the fovea, and so there's actually lots of retinal ganglion cells right there in the macula. And the retinal ganglion cells are the primary first-order sensory neurons for the afferent visual pathways. It's very interesting to potentially be able to measure the thickness of the retinal ganglion cell layer, shown in the next slide as the second layer of the retina that you come to using OCT. So we get to a potential point here where if we can measure different layers, thickness of different layers of the retina using OCT, and the technology of OCT is getting to this point now where it's literally close to virtual histology, where we can segregate out the different areas of the retina, and if you can pick them out on a microscope, it's getting to the point where you can almost pick them out using OCT. The ganglion cell layer, as I mentioned, is the second layer that you come to or that light would come to after coming into the eye. And this is of particular interest because the ganglion cell layer, as I said, contains neurons, and therefore we have not only an axonal measure using OCT, that is the peripapillary retinal nerve fiber layer that we looked at previously, but also the ganglion cell layer. I'd like to talk briefly about how we're currently using OCT in multiple sclerosis. The first use is actually as a safety measure, and we're using it to screen and monitor for macular edema in patients starting on a treatment for MS called fingolimod, which has macular edema as a potential but rare side effect. I show you here one slide of what macular edema on fingolimod looks like. You can see that the architecture of the macula is somewhat disturbed and looks almost bubbled up, and the red arrow on this slide points to cysts that are actually seen within the retina itself that cause that difference in architecture. Of note, macular edema is reversible after fingolimod, and so you can actually follow the morphologic reversal of it using OCT. However, we're also using OCT to follow the axonal loss of MS over time. The table on this slide shows a number of studies looked at in a meta-analysis by Petzold et al. In optic neuritis eyes using OCT to follow the axonal loss following optic neuritis. And you'll see that across all of these studies, there was a substantial loss of peripapillary retinal nerve fiber layer thickness following optic neuritis. And in fact, the difference or total loss of retinal nerve fiber layer on average is approximately 20 microns over time. This occurs after about 6 months following optic neuritis. So this is an impressive loss if you consider that the complete total retinal nerve fiber layer thickness is approximately 100 microns in a normal individual. To lose 20% of the retinal nerve fiber layer after a single episode of acute optic neuritis represents a high percentage of the retinal nerve fiber layer that's lost after optic neuritis. We can also look, though, at eyes that have not had optic neuritis, and even there, approximately 8 or 9 microns of loss occurs or is identified in eyes even if they've not experienced optic neuritis. So the message from these two tables is that retinal nerve fiber layer loss occurs most dramatically following optic neuritis, but also occurs slowly over time, even in eyes that have not had clinical optic neuritis. Let's then consider our last case. This is a 33-year-old woman with definite optic neuritis in the right eye, onset 1 month prior to when you see her, and her visual acuity is 20/200 in the right eye. Again, this is 1 month after she experienced onset of this optic neuritis. Her visual acuity is still pretty bad in that eye. She was treated with IV steroids for 5 days at the time she initially presented, and she completed that treatment 2 weeks ago. She has no perceived visual recovery yet, so when you ask her how her vision is, she says it hasn't gotten any better. Her exam remains essentially the same as at her initial presentation. And the question in this case is what to do with this lady. Well, we acquired an OCT, and this is what her OCT looked like. You'll see that she does have retinal nerve fiber layer loss in the right eye, and that it's down to 52 micrometers in the right eye, compared to 86 micrometers of retinal nerve fiber layer in the left eye. So here are our options of what to do. Number one, a trial of plasma exchange for a refractory deficit of vision. Number two, trial of IVIG for refractory deficit. Both of those treatments, plasma exchange and IVIG, do have some evidence that they help in patients with refractory deficits. Choice 3, additional 5 days of IV steroids. Choice 4, no additional rescue therapy for now. Concentrate on why this happened and preventing future attacks. In this case, I want to point out to you, as circled in red, that there is already substantial retinal nerve fiber layer or axon loss in the right eye compared to the left. And so in this case, I advocate for choice number 4, that is no additional rescue therapy for now. Concentrate on why this happened and prevent future attacks. The reason why this is that treatments such as plasma exchange are relatively invasive, and do carry some risk associated with them, as well as IVIG and even IV steroids. And if the patient's retinal nerve fiber layer was still preserved or did not have such dramatic loss, we would think that there may be some potential for recovery. But right now, with there having been such dramatic axon loss already occurring in that right eye, the chances of recovery of vision in that eye are extremely small. And so we, at this point, choose to avoid risk of additional rescue therapies and rather focus on why this occurred and how we prevent future attacks. In this patient, for instance, who had rather severe optic neuritis with poor recovery, one diagnosis that you may want to consider is neuromyelitis optica, a disease which causes optic neuritis that tends to occur to less of an extent than optic neuritis that occurs with multiple sclerosis. And indeed, in this patient, neuromyelitis optica wound up being the correct diagnosis, confirmed by an NMO aquaporin 4 IgG antibody test in the blood. In summary, optic neuritis is painful vision loss which occurs over days. Visual acuity typically normalizes, but often subjective complaints persist. MRI lesions on brain MRI scan are the best predictor of MS after optic neuritis, and OCT may have a growing role for investigating the visual system in MS, in some cases used to help make treatment decisions, in some cases being used most commonly in a research setting. Thank you for participating today in MS Virtual Grand Rounds. We hope that you'll join us for future presentations in the future.
Thanks, Dr. Bermel, for reviewing this critical topic for us. It's helpful to recall that optic neuritis remains a clinical diagnosis in this day and age of high technology. You emphasized the common clinical features and also showed us red flags to watch for example, painless visual loss and older age of onset, that might signal another cause of unilateral visual loss. You reviewed with us the data from the pivotal optic neuritis treatment trial, which has yielded valuable prognostic and treatment data over the many years since the trial ended. The cases you showed emphasize the central role of MRI in monitoring for the likelihood of MS and even for the presence of MS at first optic neuritis presentation. Optical Coherence Tomography has rapidly become disseminated as a non-invasive, useful technology for back-of-the-eye disorders. We can now use this to help us monitor macular edema developing with fingolimod treatment, a key step in patient safety with a useful but complex medication. You also showed us that the retinal nerve fiber layer, a window into central nervous system pathology, is involved in optic neuritis and may point us to further understanding of prognosis, pathology, and progression of optic neuritis and related disorders. You hinted at further research looking at the retinal ganglion cell layer, a technique that might inform research not only into optic neuritis, but potentially into other central brain disorders. Linking useful new technology to the clinic and research lab will allow us to further our understanding of disease while improving patient care. Thanks again, Dr. Bermel, for your talk. Remember, participants, to obtain your CME credit for this MSVGR. Thanks for your attention and interest in this series.